Hello and welcome to another episode of Cracking Addiction with Philippe Naren and Fergal Armstrong. In the episode of Cracking Addiction today, we're going to be talking about Gabapentinoids, what they are and how they work. So Fergal, if I could ask you, what are Gabapentinoids and how do they work within the body?
So I suppose the term gabapentinoid was termed to reflect the name of the first drug in the group, which was gabapentin. Now, I'm presuming that gabapentin was called gabapentin because it looks like GABA and has got a structure containing 5 things in it. I'm not entirely sure. Maybe you know. Maybe one of the viewers know. I don't know. So the question is, why is gabapentin called gabapentin? Nonetheless, gabapentin has given us the term the gabapentinoids, and the second member of this group is pregabalin. Now again, I don't know why pregabalin is called pregabalin, something to do with previous molecule, or who knows. Anyway, I think the key thing that characterizes the gabapentinoids is the fact that they act on the voltage-gated calcium channel in the presynaptic neuron. And this has the effect of inhibiting the voltage-gated calcium channel, which therefore then inhibits the ingress of calcium into the presynaptic neuron, which therefore then inhibits the process of exocytosis of synaptic vesicles, which therefore inhibits the process of synaptic neurotransmission. So that's how they work. Now, Philippe, would you care to discuss, how they, which parts of the brain they affect and their therapeutic uses?
Sure. So basically, as we've just explained, these are GABA analogs. So they essentially increase the amount of GABA that's in the presynaptic space, basically. And they act, or the clinical indications for gabapentinoids are, well, they're quite broad. They were initially marketed as anti-epileptic medications. They have indications for neuropathic pain, and those were the main indications for them. Sometimes they have been used for other indications as well, such as treatment of withdrawal symptoms in alcohol and as an adjunct to use in alcohol use disorder, but that certainly hasn't taken off in a broader sense. But essentially, the largest indication for gabapentinoid medications are as anti-epileptic medications and as analgesic medications. Is that your understanding as well, Fergal?
Yeah, so epilepsy and neuropathic pain. And in the UK, I think that also has a license for generalized anxiety disorder. But certainly in Australia, there's only 2 license indications, epilepsy and neuropathic pain. Now, I think a lot of GPs will initiate the gabapentinoids for pain, but it's not necessarily neuropathic pain. So for instance, there's a lot of pregabalin and gabapentin that's used for back pain. Now, if I could discuss pain a little bit, I mean, we understand that nociceptive pain is associated with tissue injury. So you bang a hammer on your finger when you're hammering a nail in, you get trauma and that hurts. That's nociceptive pain. Neuropathic pain is defined as pain due to a lesion, a demonstrable lesion in the somatosensory system. And that the somatosensory system starts at the fingers and goes all the way up into the brain, all right? So anywhere along that pathway, or the fingers or the toes up to the brain. There is, however, a third diagnosis of pain called a nociplastic pain, where you've got chronic pain, like chronic low back pain, but there isn't any more, there's no more tissue injury. The back is healed, but you've got chronic back pain. And so that's now termed nociplastic pain because it's not actually due to a lesion in the somatosensory system. And other examples of nociplastic pain would include, irritable bowel syndrome, visceral hyperalgesia, complex regional pain syndrome, and fibromyalgia. So I suppose they're all characterized by some form of sensitization. So moving away from the nociplastic pain and moving away from the nociceptive pain, we have this very specific diagnosis of neuropathic pain. And really, to make a diagnosis of neuropathic pain, there's a hierarchy of diagnoses. So there's Possible, probable, definite. Possible neuropathic pain can be diagnosed on history alone. So, I've got diabetes and I've got numb fingers. Probable neuropathic pain needs to be diagnosed really on examination findings. And so really what we're looking for is objective evidence of, a neurosensory deficit, in the affected part of the body. And then definite would be evidence of lesions on imaging. So really, you shouldn't really start gabapentinoids until you've got at least probable neuropathic pain. So really, you should be examining your patients for a neurological deficit, a sensory deficit. Now, I'm pretty sure that not every patient who's started on a gabapentinoid for back pain has got an examination evidence of a neurological sensory deficit. What's your view on that?
I would agree with you, Fergal. It does seem that the amount of pregabalin has certainly increased in terms of being prescribed, and the indication is not always as per the PBS guidelines here in Australia, or the fact that it is definite proven neuropathic pain. A lot of the time it seems like it's used for that chronic nociceptive or nociplastic pain that you mentioned earlier. And again, that is prescribed outside of the guidelines that are recommended for it. Yeah. And thus it's likely of limited benefit and the harms are present. So basically the harms outweigh the benefits when it's prescribed in a manner that's not indicated. And I guess segueing a tiny bit to the harms with pregabalin, Fergal, we know that the number of deaths associated with pregabalin have risen. And I think in 2013, there were only about 16 deaths associated with pregabalin. And then in 2016, that rose dramatically to about 121. And we know that there was an article, I think, in the Medical Journal of Australia in 2018 from ambulance data that found a 10-fold increase in the rate of pregabalin-related ambulance attendances since 2012. And a lot of these are unintentional overdoses of pregabalin or interactions that pregabalin has with other medications. So it's quite shocking, isn't it, that this medication has caused such significant harm and morbidity?
Yeah, it's in keeping with the opioid epidemic. I think we now have a pregabalin epidemic, and it's the coroner's data in Victoria and also the evidence of overdose data or accidental death data from the Pennington Institute. They both identify polysubstance use as a significant cause of overdose and death, and they both identify pregabalin in that mixture. And so we're now beginning to see legislative changes to try and incorporate pregabalin in various Australian real-time prescription monitoring systems. The first one was DORA in Tasmania. The second one was SafeScript in Victoria. And I don't think they actually included pregabalin in their monitoring, but the one in New South Wales and Queensland, they now include pregabalin, I think, in their monitoring.
Indeed. I guess the question that arises with this is a prescription medication and the harms are increasing, and we may not have seen the crest of it given how widely pregabalin is being prescribed. Are there any combinations of medications that you would be treading carefully with, or you would caution our listeners and viewers not to mix pregabalin with in particular?
So I think that there's a number of myths. First of all, I'd like to dispel the myths. It shouldn't be used for chronic low back pain, right? It shouldn't really be used unless you've examined someone for neuropathic pain. But chronic low back pain, don't use it. It is a sedative drug, so therefore it has the potential to interact with any other sedative. So if we go through the entire range of sedative drugs in our Australian pharmacopoeia, we've got all the opioids, all the benzodiazepines, all the sedative antipsychotics, all the sedative antidepressants, all the sedative antihistamines, and then we've got alcohol. I mean, that as a basic list, that's a pretty good starter for 10. I'd say, don't use pregabalin with these other sedating medications unless you have done an adequate risk assessment and unless you are aware of the risks. There has to be a damn good reason to contribute to someone's hypnosedative load. Now, the other point to make, it's not just about the interaction between pregabalin and all the other sedative medication. It's also about assessing the clinical risks, or rather the clinical vulnerability to overdose that the patient has. So for instance, a young fit athlete with no cardiorespiratory or hepatorenal disease is going to tolerate an increased sedative load compared to a decrepit 60-year-old who smoked all his life, got COPD, heart failure, liver impairment from chronic alcohol use disorder, and renal impairment from, untreated hypertension, So that patient is going to be more vulnerable to the potential effects of an increased hypnosedative load when we compare that to a young fit athlete, for instance. So it's about understanding what pregabalin is, or what gabapentin is, what's the potential hypnosedative load implications, and also what's the patient vulnerability. And unless you do all of those three things, you're really missing the boat in terms of risk management.
Absolutely. And I think just to highlight one of the things that you mentioned, a lot of the gabapentinoids are essentially renally excreted, and they undergo very minimal metabolism. So if anyone has even some minor renal impairment or worsening renal impairment, you really need to review the dose of these gabapentinoids, because they're not getting cleared, they can accumulate, and they can cause sedation. And I've certainly seen quite a few patients who, over time, as we age, our renal function gets worse, and you just see these patients getting progressively more and more sedated, and the combination is just disastrous. So you do really need to be aware of the dangers with these medications, which also, I guess, brings me to a second point. What's your approach to weaning the gabapentinoids, or how do you wean the gabapentinoids? Because it is a controversial issue, and it is a vexed issue. Yeah.
Can I just go back to the point that you made about the renal function before I go into this withdrawal from gabapentinoids? So just to highlight the point, when you're 80, you have 50% renal function. And that's just due to aging, right? So aging knocks off renal function, right? And there's nothing you can do about it. That's just life, right? Thankfully, we start out with roughly 4 times the renal function that we actually need. But aging reduces it by half at the age of 80. So that really highlights the vulnerability as we age to all hypnosedative drugs that are renally excreted, including the gabapentinoids. Now, moving on to this concept of dependence. I mean, I think it's absolutely incontrovertible at the moment now that there is a dependence syndrome associated with pregabalin and gabapentin. You can get physiologically dependent on these, and therefore you can develop a substance use disorder. So, I mean, I've seen patients. The top dose of pregabalin is basically 600 milligrams a day. I've had to treat someone on 3,600 milligrams. So that's 6 times the standard dose. And he was buying that illicitly off the streets. And, the question is, why? So before we get into the actual withdrawal and how we manage dependency in this situation, why is it that people misuse pregabalin, Philippe?
Ultimately, it falls into the same kind of bucket, I guess, of why anyone develops a substance use disorder. Ultimately, it becomes something along the lines of dependence, tolerance, and also what purpose the drug is serving for the patient. And a lot of the time, especially with the gabapentinoids, I've noticed a lot of people are looking for some of those euphoric sensations as well as the sedating effect, similar somewhat to some benzodiazepines. But we do know that people, especially because a lot of these medications, gabapentin is usually a TDS dosing regimen, and pregabalin is usually a BD regimen. I've certainly seen that patients usually use the medications a lot more frequently to try and get that clinical response, and then usually I find they develop tolerance and dependence in quite short time period. Has that been your experience as well?
Yeah. And going back, reflecting on what you said about, the sedation and the high euphoria. I mean, in the UK, it is licensed, I think, for generalized anxiety disorder. So it does have an anxiolytic effect. So if you're traumatized in life and you're looking for an escape from your psychological wounds, rather than going to heroin, rather than going to illicit benzodiazepines, illicit pregabalin is going to work, for you as well. But as you say, it is a drug that you can get tolerant to very quickly. And the key, it's actually, in my experience, although it's I have rarely detoxed people off gabapentin. The literature suggests that it's very difficult to come off illicit pregabalin. It's a very addictive drug. It needs to be done very, very slowly. And there is a risk of seizures and there's a risk of withdrawal agitation. What's your experience of that?
I haven't seen too many seizures of people coming off gabapentinoids per se, but I have seen a lot of agitation, and I have seen patients really be quite resistant to wean and come off gabapentin. Like you, I do a wean over a long time period, particularly in the community. Yeah. I have seen more rapid withdrawals in residential inpatient settings, and they have gone relatively unremarkably, as in the autonomic effects were not as bad as I would have expected. But with withdrawal management, the main thing is to make sure the patient is on board and that the rate of relapse is not high. And the dangers with trying to do things too quickly is that we do things to the patient rather than with the patient. And then we may be putting the patient in an area of more harm. So practically, like you, and there are different scales that different people use, but I usually come to an agreement with the patient about a fixed weaning regimen, as in, say, if someone's on 300 BD of pregabalin, say we decide to wean by 25 or 50 milligrams per week or fortnight, something that the patient's happy with and that I can do, that I can tolerate, then usually it'll be staged supply and regular monitoring to ensure that there are no real complications going that way. And usually those kind of weans are relatively uncomplicated. Has that been your experience?
Yeah, I think if you're dealing with high dose pregabalin, but nonetheless within the therapeutic range, I think that's entirely reasonable. But I'm reflecting back on the couple of patients that I've seen so far. They required inpatient detoxes for supra-physiological doses, i.e., the 3,600 milligrams. And we basically used a lot of diazepam and reduced them by half fairly quickly. And nothing, from memory, nothing happened to those patients. But I wouldn't do that in the community. If it was in the community, again, it would be daily or weekly pickup with controlled amounts and a gradual, steady wean. Here's a question for you. Would you use additional benzodiazepines in the community to facilitate a gabapentin wean? Would you, or a pregabalin wean? What would you say to someone saying, I have to have something for my nerves instead?
Not in the community. In a monitored withdrawal unit, that is essentially what we do. We usually, practically, when someone's on those therapeutic regimens that you mentioned, Fergal, what we do is we either halve the dose or cease the dose and use diazepam as a bridge, and then wean the diazepam during their inpatient stay, and then they're discharged with nothing. In the community, I would not feel confident with having two GABAergic drugs working synergistically, especially when I'm not 100% sure what exactly the gabapentinoid dosage the patient is taking and where I might not have control over that. I think that's a recipe for disaster. And we, as we said earlier in this episode, a lot of the mortality associated with gabapentinoids is usually in combination with other drugs. I think you're potentially setting yourself up for failure and complication. Would you agree with that?
Totally. It goes back to the overdose data that basically it's not necessarily one drug, it's polypharmacy. It's polypharmaceutical hypnosedative overdose with gabapentinoids and benzodiazepines together. That's where you start getting into tiger country. And so no, I would not personally use additional benzodiazepines to facilitate a gabapentinoid wean in the community. And if someone's saying they can't cope with their anxiety, well, I'd give them evidence-based anxiety treatment, which is basically SSRIs and CBT, but, I certainly wouldn't give them more Valium.
Indeed. So in the episode of Cracking Addiction today, we've talked in detail about gabapentinoids, in particular gabapentin and pregabalin. We've talked about some of the pharmacodynamics of these medications. And we've also talked about the escalating harms that we're seeing in society associated with gabapentinoids. And we've also talked a bit about withdrawal management strategies and how to wean people off gabapentin and pregabalin in the community. So thank you for your attention on this episode of Cracking Addiction, and bye for now.